Next up, somebody that may not have seen before, Rupert McShane, is going to talk to us about prospective tracking of bladder symptoms, and we're keeping a very strict eye on the time.
I promise you it's getting towards the end of the day, and actually I'm going to be very brief. Yes, this is the work that Andrew Tucker, who's an MSc student in our department, has done with Sarah and Alex Cragen, and we're very, very grateful to them for their input in this this chart review. Just a little bit of background that we know about 49% of ketamine abusers experience cystitis, and these are the sort of typical symptoms and what one sees as investigation. And the pathology of this is really related to the concentration of the ketamine in the bladder and its effect on the urothelium. So the urothelium undergoes apoptosis at a rate that it can't recover from if the concentration of the ketamine is too high. Once that barrier is breached, then the interstitial cells start to be affected. The pain fibers underlying that are affected, and then the destrucer smooth muscle. And so that's what underpins the pathology of the ketamine bladder. And eventually you get neorevascularization and neurogenesis, all of which make it much more painful. This very nice case study was published from the King's Group of what happens with medical ketamine, because that's really what we're more interested in here. And this was of a 28-year-old woman who'd had past history of ECT. She was given 160 milligram sublingual lozenges twice a week, and then 3 times a week, and then 240 milligram capsules orally 4 times a week. So that's a total weekly dosage of 480, 960, isn't it? So she responded well anyway to that, but developed dysuria that lasted 2 hours pretty reliably after each dose that she took. And she had a sterile pyuria, but no hematuria. And when she stopped the ketamine, the dysuria stopped within 3 weeks, and her mood relapsed. And what she wrote about this was, sadly, the urinary symptoms were horrible. They felt like a really bad UTI, and the pain lingered longer each time. In the end, the urinary symptoms made me start to dread each dose of ketamine, as I knew that the pain would be there for most of the day and night afterwards. As a result, making the decision to stop the ketamine was a difficult one, but so was the idea of continuing it. In the SUSTAIN-3 study of Spravato, these are the incidences of various urinary symptoms. So low, but they're there. So the method of this study, this was an analysis of all the data that we had from our ketamine clinic patients between April 2010 and January 2022. They all had TRD. 77% of them were paying for their ketamine treatment out of pocket. And our standard clinic protocol is that we start with 6 IV inductions over 3 to 6 weeks. We started with 0.5 milligrams per kilogram, typically increasing to 0.7 milligrams per kilogram at this stage. Subsequent to this study, actually, we've started to go a little bit higher than this, I think. And our general way of doing it is to titrate to dissociation. From July 2018, we introduced, because of the problems in managing clinic throughput, we introduced the idea of have people having weekly oral ketamine that could be taken either at home, it was always taken at home, but they always had an in-clinic oral dose to see how they got on with it before they had oral ketamine at home. And so people would typically have an intravenous infusion, then a week later an oral, then intravenous 4 weeks. So that's the sort of pattern. And the outcomes that were interested in here are the Beck Depression Inventory, self-completed questionnaire, and this interstitial cystitis problems and symptoms indices. So every time they came into clinic, they completed this questionnaire, which is basically asks in the last month, and then it's these 8 items. So there are the symptoms are rated on a 5-point scale: strong need to urinate with little or no warning, urinating less than 2 hours after you've finished, nocturia and dysuria, and then how much of a problem were those on a 4-point scale of these: frequent urination, getting up at night to urinate, needing to urinate with little problem, and burning pain or pressure. And the results were that we had 295 patients, of whom 52% were male. The mean duration of ketamine treatment was 402 days, so that makes a sort of person years exposure of 324. And really, I've only got 2 results to present. And the first one is that somewhat to our surprise, the relationship between the ketamine and the bladder score was that compared to the baseline here, the scores on this scale were lower after ketamine rather than higher. And we looked at this in a number of different ways. So first was what was the maximum oral dose, and this was the maximum intravenous dose, and then the final dose. We also did an analysis looking at cumulative dose, which broadly bore that out. So the question is really, well, why? Why should that be? Why should their bladder scores actually get better with ketamine? And we wondered whether there was something to do with the fact that people who are anxious need to go to the loo a lot. So could this be simply that the ketamine was treating their anxiety? There's a very, very weak relationship between the change in the BDI score, so these people were getting better here, and the change in their IPSI score. So it was a very weak correlation. So the answer to that is probably not that. What of more importance really is to look at what happens to people who've been exposed to a lot of ketamine, and also people who have got the fewer people that had the high changes in their bladder scores. So I'm just going to run through that very briefly. So we had 10 patients who had a cumulative exposure of more than 40 grams of ketamine. Most of that would have been oral ketamine, because the doses of oral ketamine were much higher than the doses of the intravenous, for obvious reasons. So here we had a patient with a cumulative dose of 90 grams over 4.2 years. And you can see here that the difference between, there was basically no increase in the interstitial cystitis scores, and that was the same for all of these cases here. We had one patient who had very high scores, and that she was somebody who had pre-existing structural abnormality and had to self-catheterize herself. It was part of the reason she was so miserable, and she was having pre-existing UTIs and incontinence. So really, there was these patients with high cumulative exposure had no particularly marked changes in their scores. And then if we look at the few patients who did have the higher changes in their scores, so here these are people who had a score of more than that increased by more than 10 after their induction period. What you can see, we basically looked back at the notes to just see what happened to them. And so this case here, she stopped after the induction because of increasing urinary symptoms, but which resolved on cessation. Okay, we don't know, of course, what would have happened if she carried on. The second patient here stopped due to a lack of clinical efficacy. and she had proteinuria and was referred to the GP. The symptoms resolved spontaneously. So again, don't know what would have happened there if she'd carried on with the ketamine. This person stopped due to intermittent abdominal symptoms, and we didn't know anything. We didn't really know much about what had happened to him until we chased him down in order to find out what happened to him for the purposes of this analysis. And it turns out that he'd had a lot of UTIs and in fact had recurrent renal calculi. And he was a bit exercised to hear about he suddenly said, well, do you think that the ketamine might have caused this? To which I think the answer is almost certainly no. He'd had some he'd had some baseline symptoms, but there's a possibility, I guess, it might be that the calculi made him a bit more vulnerable to anything that was going on in the urinary tract as a result of the ketamine. This patient stopped due to dysuria and nocturia. There was no UTI on urine analysis. So again, they got better. They restarted it 4 years later and in fact ended up having quite a lot of ketamine with no real increase in their cystitis score. This patient paused twice and resumed successfully, received a lot of ketamine, and this person stopped after the induction phase, but it wasn't not because of the urinary symptoms. So there's a few cases here that where you don't know what would have happened had they carried on, but in all the cases, they stopped for clinical reasons. So the possible interpretations are, there's no clinically important risk of bladder damage, but it depends a bit on whether you're a glass half full or a glass half empty sort of person. I tend to be rather half empty. But, so it could be that we just averted the risk of damage, or of course it could be that the symptoms were suppressed by the antidepressant or analgesic effects. And if you're a sort of anti-ketamine lobbyist, I guess that's the one you'd choose, or maybe it's analgesic. Or it may just have been that higher or more frequent medical doses might still cause interstitial cystitis. So, but our data look fairly reassuring. And the other thing, just to the other take-home message really, was that we found that actually tracking these urinary symptoms was quite helpful to us, because every time somebody complained about their symptoms, we could look back and see what their previous symptoms were, what their scores were, and it helped us to just determine and be just a bit more informed about when to take urine specimens. So I have a question for you just to finish off with, and that is, on the basis of these data, do you think that formal tracking of urinary symptoms is necessary? And if so, at what frequency? And when would you actually decide to do a dip test on the urine? So thank you very much.
Thanks, Rupert. Looks like Colleen's got an answer to your question.
Good, yeah, it's answers only at the moment. No questions, please.
It's actually just a comment on terminology. Thank you for raising a really important point, Rupert. And it's the kind of the interstitial cystitis as opposed to cystitis. So when I read the Janssen long-term studies, they'll report people with symptoms of cystitis, but that there was no interstitial cystitis, by which I think they mean it's a pathological diagnosis, based on cystoscopy and biopsy. Whereas we tend to use scales which have symptoms of interstitial cystitis. And then when people score something, we're saying they have symptoms of interstitial cystitis. And I've heard some people who have been quite confused about this in the field, saying that Spravato does not lead to interstitial cystitis, based on those studies and the terminology being precisely used, but that racemic ketamine is leading to interstitial cystitis based purely on people reporting symptoms of dysuria. Because if you read the Spravato long-term studies, there are people reporting symptoms of dysuria. They just haven't had interstitial cystitis on cystoscopy and biopsies. But I just think we need to be very careful about the terminology.
Yeah, sorry if I was a bit sloppy with the language here. You're absolutely right. And the obviously it's partly driven by the fact that the scale is called the interstitial cystitis scale. but it's just really measuring symptoms, as you say. Yeah. What about an answer to my question, though? Robert?
this time we're right. Very interesting, Rupert. Thank you. I think we have similar experience, similar data also. I think we have very little, maybe not even one patient that we had who had proven interstitial or otherwise cystitis. We track it, so it's part of our monitoring module.
How often do you do it? How often do you
online.
do it? How do you track it?
It's part of, so the questionnaire is, I don't know how often do we do it? Yeah,
Every month.
Every
we
month.
use the same questionnaire. Yeah. Okay. So that's whenever somebody has treatment, is it, or is it? I suppose if you're giving them twice a week, it's once a month. Yeah. So you have to schedule it. Yeah.
Yeah, and we also do a urine check every 6 months. Yeah.
Okay.
But so we are going to look more formally at those data, and then I think so. It seems to be very much a dose-response relationship. So in the dosages and the frequencies that we currently use, luckily the chances seem to be very low. And then it's maybe more a matter of being very prudent and responsible. And we should, I think, publish these kind of findings in order for the field to advance.
Good. It's a good example of the sort of thing that's easier to track when you're part of a secondary care service, isn't it? Perhaps than when you're part of a primary care service. Anybody else got ideas about the formal tracking?
Yeah, I think we've got time for one more comment,
right.
and then we have to.
Is it on the REMS? Is there any question? Do you know? Is there a question about urinary symptoms on the REMS?
The 3008 trial.
No, I know, but now there's 58,000 people, 1 million doses. If it was on there, we'd see it now.
There's not a specific question. It's just like adverse effects, and then you can fill in whatever.
Yeah, it's opportunistic, and the question is whether that's enough or whether we actually need to continue to formally track it because of the known relationship. Anyway.
Great. Thank you very much, Rupert.
Thank you.